This video will guide you through a dog spay from start to finish. Spays are often described as a routine surgery, but in reality they can feel complex and stressful. If you've ever felt unsure or lacking confidence, you're not alone. While there are many valid ways to perform a spay, the method shown here is one we've found to work well across a wide range of clinical environments. We hope it helps you to build your confidence and develop your own surgical style over time. Start by placing the towel clamps and then check with your anaesthetist that they are happy for you to begin. First, identify the umbilicus. This should be easy to see, but if not, can be confirmed by drawing a line between the last ribs, and where it intersects with the midline, the umbilicus is slightly caudal to this point. The start of the incision should be 1 to 2 fingers width caudal to the umbilicus. In pregnant or deep-chested dogs, it should be started more cranially. The incision should be about 5 to 7 centimeters in a medium-sized dog. Extend the incision caudally. Be confident with your first incision and apply enough pressure to cut through the skin layers in one go, avoiding cutting the skin multiple times, which creates unnecessary trauma. Dissect through the subcutaneous tissue to expose the linea alba using forceps and scissors. You can use sharp or blunt dissection depending on which you're more confident with. Try not to dissect more than you need to, as it creates dead space which can delay healing and also lead to hematomas. Approximately 5 to 10 millimeters of muscle fascia should be made visible around the linea alba. The linea alba is a subtle white fibrous band where the abdominal muscles attach together. It also feels like a small firm depression at the midline. Use the rat-toothed forceps to lift up the linea alba. This will lift the muscle away from the abdominal contents so that you don't accidentally damage the internal organs when you insert the blade. Hold your scalpel with the sharp side facing upwards and make a small stab incision through the linea alba into the abdominal cavity. If you have accidentally incised slightly off the linea alba, ensure that you have also cut through the peritoneum. Place your thumb forceps into the small incision, using them to hold up the muscle. You may then extend your incision cranially and caudally using Mayo scissors. The forceps act as a guide to help you cut the linea alba and hold up the muscle to keep the scissors away from abdominal organs. You should hear the characteristic crunch cutting sound as you cut along the linea alba. Once you are in the abdominal cavity, locate a uterine horn. There are multiple techniques to do this, for example, by running your index finger down along the abdominal wall and gently pulling it back up in a hook shape until you feel it catch on the uterine horn. Sometimes omentum can be wrapped around the uterus, and you may find that this is pulled up as well. This is okay, and it can be gently returned to the abdomen once you have hold of the uterus. Confirm that it is indeed the uterus by following it to the bifurcation or the other way to the ovary. Locate the red spot on the ovary and hold the proper ligament between your thumb and index finger with your right hand. While stabilizing the ovary in this manner, you will have the proper ligament, red spot and suspensory ligament all in a straight line. This will make the suspensory ligament easier to visualize and feel, therefore making it easier to know what to stretch. Feel for the suspensory ligament, the 1 to 2 mm wide tight band below your fingers. It attaches to the cranial end of the ovary and then down into the abdomen at the point of the last rib. With your left hand, hold the suspensory ligament between your thumb and index finger below the ovary. Then, slowly stretch the suspensory ligament by moving it side to side and upwards at the same time with your fingers. Stretch the ligament until there is enough space to place 2 clamps below the ovary. You may or may not feel a little snap as the ligament comes loose from its base, but nothing is actually broken and therefore there is also no bleeding. Pressure should never be applied to the entire ovarian pedicle, which contains the ovarian artery. Make a window in the non-fatty avascular part of the broad ligament. The window should be at the level of the ovary but 5 to 10 mm away from the ovarian pedicle. Place the first clamp, clamp 1, through the window and across the ovarian pedicle below the ovary. Place the second clamp, clamp 2, approximately 5 to 10 mm below the first. Palpate around the clamps to make sure you haven't trapped any of the tissues alongside the ovarian pedicle, such as omentum or abdominal muscle. Place the first ligature 5 to 10 mm below clamp 2. If it is too close to clamp 2, the ligature will not tighten and will risk slipping off. Here we are using chromic catgut for ligations, but other suitable suture material may be used. A good ligature compresses the pedicle so that there is a visible dent in the pedicle and no other tissues are caught within the ligature. Hold the instruments and gently retract the abdominal wall in order to give yourself the best visibility. Here we are tying a square knot, which is the most appropriate knot when using catgut. Ensure a total of 4 throws are placed above the square knot. Loosely tie the first knot of the second ligature around clamp number 2. Then remove clamp number 2 so that you can reposition it elsewhere. If you have the space, you can place the clamp above clamp 1 near the ovary. If there isn't the space, you can place it on the other side of the ovary where the proper ligament inserts onto the ovary. The second ligature is then placed into the crush site of clamp 2. Again, ensure that a total of 4 throws are placed on top of the first secure square knot. Check that you are happy with the ligatures and that there are no other tissues caught in them. Steady the ovary, then transect carefully the tissue below it. Use clamp 1 as a guide and run the scalpel blade over it for stability. Check that the ovary has been removed in its entirety. This should feel like a smooth, firm ball shape within the bursa. Hold the stump between the top ligature and the clamp with rat-toothed forceps or Alice tissue forceps in your non-dominant hand. Do not grasp the ligature itself. Gently release the artery forceps holding the stump and check for bleeding. When you've confirmed that there is no bleeding, gently return the ovarian pedicle into the abdomen. Next, Separate the broad ligament from the uterine horn, avoiding damaging the uterine artery. If the broad ligament is highly vascularized, create a window in an avascular portion at the level of the bifurcation. Then place a clamp across the broad ligament before placing a ligature 5 to 10 millimeters below the clamp. Then place a second clamp above the first. Keep the lower clamp stable with your left hand as you use your right hand to hold the upper clamp, and in a controlled manner, gently rotate and tear it away from the lower clamp. Always remove the clamp nearest to the ovary first to check for bleeding. If there is none, whilst holding the broad ligament with the rat-toothed forceps, remove the lower clamp and again check that there is no bleeding. If there is no bleeding, release the broad ligament back into the abdomen. Then, find the uterine bifurcation and use this to follow the uterine horn to find the opposite ovary. Using the same technique described and shown for the first ovary, we will then remove the second ovary. Once again, locate the red spot on the ovary and hold the proper ligament between your thumb and index finger with your right hand. With your left hand, hold the suspensory ligament between your thumb and index finger below the ovary. Then slowly stretch the suspensory ligament by moving it side to side and upwards at the same time with your fingers. Here, you can actually see the suspensory ligament snap as it is stretched. Make a window in the non-fatty avascular part of the broad ligament. The window should be at the level of the ovary, but 5 to 10 millimeters away from the ovarian pedicle. This can be done with your fingers or with a clamp. Place the first clamp, clamp 1, through the window and across the ovarian pedicle below the ovary. Place the second clamp, clamp 2, approximately 5 to 10 millimeters below the first. Remember to place the first ligature 5 to 10 millimeters below clamp 2. Ensure a total of 4 throws are placed above the first secure square knot. Loosely tie the first knot of the second ligature around clamp number 2. Remove clamp number 2 so that you can reposition it elsewhere. The second ligature is then placed into the crush site of clamp 2. Again, ensure that a total of 4 throws are placed on top of the first secure square knot. Check that you are happy with the ligatures and that there are no other tissues caught in them. Steady the ovary, then transect carefully the tissue below it. Check that the ovary has been removed in its entirety. Hold the stump between the top ligature and the clamp with rat-toothed forceps or Alice tissue forceps. Gently release the artery forceps holding the stump and check for bleeding. When you have confirmed that there is no bleeding, gently return the ovarian pedicle into the abdomen. Create a window in the broad ligament at the level of the bifurcation. If the broad ligament is not highly vascularized, as is the case on this side, 2 clamps can be placed across the broad ligament before gently tearing between the two without placing a ligature. Even so, always remove the clamp nearest to the ovary first to double check for bleeding. No bleeding is seen here, but if bleeding is noticed, a ligature can be placed below the lower clamp at this stage. Then, whilst holding the broad ligament, check for bleeding again once the lower clamp is removed. If there is no bleeding, release the broad ligament back into the abdomen. Then, locate the uterine body by following a uterine horn to the bifurcation. Identify the cervix by palpation. It feels much thicker and firmer than the uterine body. Place your clamps 10 mm apart on the uterine body above the cervix. The technique used to ligate the uterine body will vary depending on the patient. In most cases, ligation can be performed in the same manner as the ovarian pedicles. In older dogs, pregnant dogs, or those with a pyometra, the uterine arteries are large and are at greater risk of bleeding. In these situations, a transfixing ligature can be considered. Here, we will be using encircling ligatures, as we did with the ovarian pedicles. The first encircling ligature is tied between the cervix and the clamp nearest to it using a square knot and 4 additional throws. Take care not to include the cervix in the ligature. Loosely tie the second ligature around the clamp nearest to the cervix. Then remove the clamp and place it above the remaining one before tightening the ligature into the crush mark. You can see that whilst tightening the ligature firmly, the suture material can sometimes break. This is okay as long as there is still enough length of suture material to be able to place the remaining throws. and you are still able to create a safe, secure knot. Otherwise, you would need to tie a replacement ligature with new suture material. Check that you are happy with your ligatures and that there are no other tissues caught in them. Once the uterine body has been ligated, cut the uterine body between these two clamps. Hold the uterus up so that there is no risk of cutting any other tissues with the scalpel blade as you do so. Grasp the uterine stump with rat-toothed forceps, avoiding the ligatures as before. Observe the uterine stump for bleeding. The stump can be released back into the abdomen. Next, we must check for hemorrhage at the ligature sites before closing up. To do this, clamp a clean swab to a pair of forceps and gently guide this down into the areas where the ligatures are to identify any bleeding. Use a clean swab for each ligature site. If there is any active bleeding, religate the affected stumps. With active bleeding, there is usually a large amount of pooling fresh blood with a number of blood clots. The amount of blood on the swabs in this video is considered normal. If there is no active bleeding, you can now close the abdomen. Closure of the muscle layer is achieved using a simple continuous suture pattern. Suture bites should be 4 to 5 mm from the edge of the incision and must include the muscle fascia, as this is the strongest layer. This thickened, pale, shiny surface is the fascia. 1/0 PGA is used in this video. Start at the caudal end and place the starting knot by taking bites of the muscle beyond where the incision starts. Tie a surgeon's knot and then place 5 additional throws. Bites should be 5 mm apart from each other and be consistent. Avoid slanting bites. Bites should be perpendicular to the incision. Use your rat-toothed forceps to hold up the muscle edges to make it easier for you to pass your needle through without potentially damaging any organs underneath. Apposition of the wound edges should be snug enough to avoid dehiscence and herniation, but not too tight, as this can lead to necrosis. Once at the end of the incision, tie another secure surgeon's knot with 6 additional throws just beyond the end. If you are unable to visualize the end of the muscle incision clearly, lift the muscle layer up by pulling on the suture material and then place 1 to 2 carefully guided bites just beyond the cranial end before tying your knot. Cut the suture ends fairly short. Palpate the suture line in the muscle to ensure that there is a tight seal. Any areas that give way to gentle pressure may indicate a weakness point. If there are just 1 to 2 areas, place some additional simple interrupted sutures. If the whole suture line is weak, redo the muscle layer. The subcutaneous layer should be started from the cranial end of the incision, directing your needle inside to outside on one side. And then outside to inside on the other side, before tying a secure surgeon's knot with 5 additional throws. This will help to bury the knot. Then the first bite should be taken from inside to outside so that the knot stays buried. You can then continue a simple continuous suture pattern until the end of the incision. As you proceed, check that the dead space is reducing. Although not shown in this video, if you need to, you can take a bite of muscle fascia as well as your subcutaneous layer to help minimize the dead space. To finish the subcutaneous layer, place another secure surgeon's knot with 6 additional throws. Cut the short end, but keep the long end attached so that the same suture material can be used for the intradermal layer. This technique should only be used if the suture material used for the subcutaneous layer is also suitable for the skin layer. Then, by holding the suture material upwards, guide the needle subcutaneously behind the knot and then poke it out at the caudal edge of the dermal skin layer, giving the knot enough space to bury. You can now start your intradermal skin layer directly from here. Bites are taken in the dermal layer in a horizontal orientation. Bites should be 4 to 5 mm long and deep enough that the bite is secure. Observe carefully where you previously exited and enter slightly ahead of that on the opposite side to avoid gaps. Holding the cranial third of the needle with your needle holders can really help to improve your control. When intradermals are done really well, it should be difficult to see that there was ever an incision made in the first place. When you start approaching the end, begin to plan your final knot in advance. Ensure that you take an adequate amount of tissue in your last bite to provide strength to the knot. Ensure that your intradermal layer is secure and that no suture has pierced through the outer skin before tying an Aberdeen knot. Placing 3 to 4 throws before locking the knot is adequate. Bury the knot by holding the needle perpendicular to the incision site and direct the needle through a suitable gap adjacent to the Aberdeen knot and then exit through the intact skin at least 2 centimeters from the suture line. Pull the suture material carefully until you hear the characteristic pop sound of the knot being buried. Now cut the suture material close to the skin. Your surgery is now complete. Thank you for watching our WVS Academy video on how to perform a dog spay. We hope this has been a useful, supportive guide and helps you to continue to build confidence in your approach to spay surgeries.